Welcome everybody to the PSPS, the first of hopefully many leadership immersion tracked webinar. I'm going to do a brief introduction here. My name is Dr. David Lee. I practice here in Southern California. Unfortunately, I'm joined by our moderators, Dr. Momani and Dr. Katzen, who are also in Southern California, also PM&R trained. So I'll start with Dr. Momani. She's out in Orange County, right in my backyard. She practices as a coast spine and sports medicine. She completed a physical medicine rehabilitation residency at UCLA, and then subsequently an ACGME pain fellowship at UCSD. So we want to thank her for being here. And Dr. Seth Katzen similarly graduated from UC San Diego ACGME accredited pain fellowship, was previously trained prior to that at Washington University in St. Louis, also in physical medicine rehabilitation. So I'm going to ask Dr. Alan Lin, who's been kind of my right-sided man along this past year for LIT, just to give some brief introduction as to what the LIT program is and what we've been doing. Alan, do you mind kind of chiming in here?
Yep. And everyone call me Alan. I think Dr. Lin is very boring. Don't use that. And so we actually continue the work and set up mostly by Dr. Lee and a few others, as a lead program. And the whole purpose of this program is just to nurture anybody who's still under training as a residency or fellowship or kind of early stage of their career. Find the right target, find the right market, find actually something you are capable with, and also try to reach your limit if you believe there is, or we help you to go through that. I think it's a very academic at the same time, very casual, supportive network for pretty much everybody here.
Yeah, that's great. We've been doing monthly meetings. We continue to do so. Our next meeting is going to be with Dr. Michael O. He's a neurosurgeon here in our backyard at UC Irvine. But for all of you guys on this call, I'm going to hand things over now to Dr. Momani, Dr. Katzen.
All right. So basically the structure of the panel is going to be me and Dr. Katzen will be asking a question. Before we do that, we'll have the person who's going to be answering the question introduce himself briefly. And then we're just going to ask that if the audience has any questions, if you can just hold on to them until the very end, and then whatever time we have left, we can try to address them. And then if people are really passionate and want to stay on longer, you're more than welcome to, but we're going to try to really keep it to a strict schedule. So I'll be timing, and basically at 4 minutes, I may interrupt and be like, okay, we have a minute to wrap up, just so we can make sure that everyone can have an equal chance to spread the wisdom. And hopefully this is really helpful for you guys.
All right, so we're going to jump straight into it. Thanks, Dr. Lee. Thanks, Dr. Lin, for all your mentorship and guidance through this process. This is a great group to be in, so we're really looking forward to fresh blood and people coming in to give their perspectives on things and learn a lot about the field. Our first section that we're going to start off with is entitled Navigating Residency to Fellowship Successfully. We've got a couple great panelists here that are going to answer some questions, Dr. Garcia, Dr. Mata, and Dr. Pasternak. Two of them are currently residents, and one is a fellow ending fellowship here soon. So we'll have a nice diverse amount of perspective on some of the questions that we're going to answer and ask. So the first person we're going to start with is Dr. Garcia. I'm going to ask you a question, but before you answer the question, if you could give a brief introduction about yourself, that'd be great. The question for you is, as a resident applying to pain medicine fellowship, how much has mentorship played a role in the process? And how have you gone about seeking mentorship in your respective residency program or beyond?
So good evening, everyone. My name is Rosa Garcia. I am currently performing my physical medicine and rehabilitation training at Larkin Hospital Health System here in Miami, Florida. And I am excited to be here today and share my journey with all of you. So mentorship has been very crucial in my journey towards applying to a pain medicine fellowship. And this really began very early into my residency when I decided to seek for mentors who had, a genuine interest in empowering and guiding early career physicians. So when I was looking for my mentor, beginning in the beginning of my residency and beyond my institution, I really tried to look for somebody that whose work really aligned with my interest in the field of pain medicine. In addition, I attended national conferences. I also tried to join different types of societies such as PSPS, ASPN, and others. And it is really important to participate in these societies because sometimes they also have individualized mentorship programs in which you can participate and have your one-to-one mentor, assigned and based on your interest. Another thing that really helped me out was reaching out for early career physicians who had already accomplished a successful pain medicine fellowship. And their input was very, helpful in my process of applicating to a pain fellowship. So at the beginning, I did have one mentor, but ultimately I had multiple mentors, and I would strongly, recommend everybody to take every opportunity to learn and, just be a sponge. So, it is important to be judicious when you are trying to select your mentor, but you also have to be very committed to your personal growth and your development, right? You have to be somebody that's persistent, try to be present in the conferences, try to participate in these discussions, be a hard worker, and always try to ask for the opportunities, because if you don't ask, then you'll never know if those opportunities, are going to be available for you. As a mentee, I think it is important to understand that you might, fail in certain circumstances, but you have to understand that you are going to learn from your failures. And the whole idea of having a mentor is having somebody that's going to guide you on how to navigate those failures and accomplish, your goals. So ultimately, to me, my mentors have been super, they've been very supportful. They've given me a lot of support, and they've helped me a lot with my personal and professional development. And they've helped me accelerate my career and give me that confidence that is needed in order to navigate in the specialty of pain medicine, which is so competitive.
Well, that was a fantastic answer. Have you used social media at all to help you connect with people outside of your area?
Absolutely. I think social media is a great platform, and it really depends on the type of target that you kind of want to attract. In my personal experience, I really wanted to expose myself to a little bit more professional, other colleagues that were doing other types of procedures that I didn't have a lot of insight about. So I definitely started with LinkedIn, and I also use Instagram. But I think any type of social media that you use in order to improve your engagement and to kind of promote your own brand, right? And show everything, all your potential and everything that you're working on is very helpful during this process.
Awesome.
Awesome. Thank you so much. That was a great answer. Okay, I'm going to move on to our next panelist, Dr. Mata. SoFlo, South Florida in the house, it sounds like. The question for you is when did you start building your resume for fellowship? I believe you'll be applying here soon. And what advice would you give others who are trying to put together a competitive application?
Thanks, Dr. Katzen. That's a great question. My name's Robin Mata. I'm a PGY3, University of Miami, PM&R, also applying this cycle. One great starting point when attacking this question is really looking at the overall format of the ERAS application, because that's what most people will be filling out if they apply to an ACGME program. The main areas to focus on are leadership, presentations, publications, and volunteering. Ultimately, each person's application is going to look different. So try not to put a tremendous amount of pressure on yourself wherever you are in the application cycle. If you're not there yet, or if you're getting ready for that, just start by identifying opportunities that are around you. I knew I was interested in pain before starting residency, but that doesn't necessarily mean I had a lot of things on my resume that pertain to the career. Really wasn't up until the end of my PGY2 year and the beginning of my PGY3 that some of my more substantial activities actually came to fruition. So there is time. I think an important note is that if you're looking for these kinds of opportunities within your own hospital system or rotations that you're on and you're not finding them, don't be afraid to go outside. And so what I mean by that are touching on what Dr. Garcia just mentioned, attending conferences, if you have elective time, reaching out to potential mentors and going to do a week's worth elective rotation with them, or reaching out via social media can be really helpful for you to open new doors. Professional societies like PSPS are a wonderful way to identify those mentors. You can find leadership positions within societies, and you can also get involved with research projects potentially. So I found that to be very helpful. I also gained a lot from taking elective time to shadow physicians in different practice settings. That actually helped me find out that I wanted to do private practice with clinical research. It's also a great way to get letters of recommendation for your application and target a mentor. And then if you don't know where to start, but you can identify leaders in the field or even just residents or fellows who maybe are a little bit further along that career path, reach out. You'd kind of be surprised what kind of interactions can come out of that or how willing people might be to help you or give suggestions specific to your situation. So getting different perspectives can be extremely helpful. So definitely reach out. I want to talk about the slide. So one of the things that my mentor within my program kind of pointed out to me, even though he wasn't really paying, was try to make sure your application's well balanced, right? So it's not that you have a ton of research, but you don't have anything for leadership or you don't have anything for volunteering. So I put together some examples of ways that you can get this on your resume. So under leadership, residency roles, things that you hold within your residency, whether you're an outpatient program evaluation committee rep or wellness chair, whatever roles that you hold of leadership, make sure that you integrate that into your application. National roles, we talked about professional societies as a great way, but there's also regional roles, right? So PSPS or whatever flavor of SIP you have, whether that's FSIP, GSIP, OSIP, NYSIP, trying to get involved with your local societies, for me was tremendously helpful and I learned a lot. Presentations is probably the lowest hanging fruit and the easiest starting point for everyone. Case reports, right? So identify someone in your hospital through a conference, through social media, or a resident or a fellow, and ask if they have a case report. Submit it to a conference. That's a great way to also build your social media. Any presentations you give on rotations, didactics lectures, resident teaching that you do for med students or journal clubs all count as presentations. So whenever I found an opportunity to incorporate a pain topic that met that curriculum need, I would give that presentation and put it on my resume. And then the second step to build into publications is take those case reports that you presented and get them published, right? So pain medicine case reports, journals, curious.com, lots of different places to go to get those case reports published. You can also look for online publications, things like Medscape, PM&R Now articles, Stat Pearls, online publications to kind of help round out your application. And then also reach out to seniors, mentors for collaboration. If you want to move on to things like retrospective chart reviews, that's pretty feasible during your residency if you start in your second year. Things like that look great and they're definitely doable. And one other point I want to just really quickly touch on, share the love. One thing that has helped me tremendously is sometimes you feel like, oh, I have all these other co-residents that are applying for pain and I have to gun really hard and make sure my application's the best. When you find an opportunity that you can bring another author on, collaborate, share the love, right? Because ultimately we're all going to make it there. We're all going to be colleagues one day at pain meetings. So it's best to start now. And then a lot of times those people will turn around and say, hey, thank you so much for that invitation to that paper. I actually have this invitation to a paper. That has opened up exponential projects for me. So definitely share the love. And then finally, volunteering. Make sure you're a well-rounded individual. and also feed your soul in this building process. Doesn't have to be pain related.
And wrap it up like 10 seconds.
Yep, specialty specific, and then mentoring med students also counts. Thank you.
That was a fantastic perspective. I think you really encompass a lot there. Those were all super important points. Loved it. The last panelist in this section is Dr. Pasternak. Dr. Pasternak is a current fellow, so we're kind of changing gears a little bit. She's finishing fellowship up. I'll let her introduce herself. But the question for her is, now that you are a fellow or, you know, ending fellowship here, and you see the importance of diverse training in fellowship, are there any questions you wish you would have asked during fellowship interviews that may have helped you in your decision to pick a program? And should the applicants that are applying ask those tough questions during interviews about the program that they're applying and interviewing for?
Great, thank you. Yes, I'm Laura Pasternak. I did my anesthesia training at UCSF. I'm currently finishing up fellowship at UCLA. In terms of the first question, you know, things I wish I would have thought to ask. One thing I didn't know to ask at the start of this training, but I do find quite invaluable, is do the fellows in the program work at the same location in the same room, or are they kind of spread out at different institutions, different hospitals, different clinics? At UCLA, we're all at one site. We all share the same room. And I feel, to Robin's point, that collaboration of being able to get the perspective of my co-fellows, also have this sense of family and camaraderie, that which we don't really have during anesthesia residency, has been great. And shared knowledge. You know, you should ask the low-hanging fruit questions like, what advanced procedures do you do? But also consider asking the less common basic bread and butter procedures in terms of, do you do any AA joint injections? Do you do any cervical transforaminal injections? What about intradiscal injections? Those are things worth noting. The advanced open procedures are things like SES, DRG, PNS, SI, joint fusion. You also want to know, to what degree does the fellowship partner with industry? Are they very adverse to having industry involved in training? Are they okay with their fellows going off on the weekends and getting training through Medtronic, Boston Scientific, device industries? And then you want to know the degree of schedule flexibility in order for you to attend these conferences with various industries, but also to attend invaluable conferences like the PSPS conference, which we had, which I will say was one of the best I've been to. And this weekend, actually, I'm going to an orthobiologics conference to learn more about PRP and stem cell therapy. I wouldn't have had that necessarily at a different program. So you want your program to have the flexibility to accommodate pursuing your dreams, essentially. In terms of asking the tougher questions during the interview, I think it's fair to ask tougher questions. You don't want to be a contrarian, but the best advice I can give is, you first want to know your home institution's pain program director's perspective. What do they think about the institution you're applying to? Does that institution have a reputation? Are they highly interventional based, or are they more medication management? You can also, if you want to go above and beyond, find the reps for companies like Medtronic, Boston Scientific, Abbott within the area where you're thinking of applying, and try to get a sense for how well trained are the fellows who are coming out of the program. You know, are you going to ask around the community about a certain, what is the reputation of a certain fellow or a certain fellowship? It really depends. I think if you ask a community chronic pain doctor, what do you think about this candidate who trained at one specific institution, that's not a sample size large enough to make a reputation. But if you notice that a certain community chronic pain doctor consistently sees poor performance or good performance from people who've graduated from a fellowship program, I think that's worth noting. And then definitely ask the questions you want answered during interview day. I mean, they're interviewing you and you're interviewing them, and you just want to make sure it's the right fit for you. Thank you.
Awesome. That's the 4-minute warning.
Yeah, that's great. I love some of the points you brought up. I think especially the point about bringing up the certain fellowships relationship with industry is very important, especially if you're planning to go into private practice, because those are skills that you don't learn if you don't have exposure to that and how to interact with those people. So I really appreciate that perspective. All right, I'm going to go ahead and hand it over to my co-moderator, Dr. Mohamani, and she's going to take over this next section.
All right. Thanks, Dr. Katzen. So so today for my section, we'll be talking about transitioning from that fellowship to the real world and what that practice is like. So I'm pleased to have Dr. Gill and Dr. Let me see if I'll say it right, Baburia. I might have butchered a little bit, sorry. So we'll be asking them. And so I'll ask a question, I'll have them introduce themselves. And then if there's time for discussion, we can go more into it. So our first question is to Dr. Gill. So I'll let you introduce yourself and then I'll go ahead and ask the question.
Well, thanks, Dr. Mohamani. I'm Benjamin Gill. I'm in the final phase of pain fellowship at University of Utah. My background's in physical medicine and rehab.
Awesome. So now that you're, pretty much at the end of your fellowship year, either probably have a month or so left. So with this part of your fellowship, now that you're moving towards the latter half, have you gotten exposure to what we would call real world medicine? So billing, coding, things that are important that they may not emphasize, especially in the beginning of fellowship, because you're learning a whole nother, set of procedures and medications. Yeah. So during your fellowship year, have you had any time to work on this or kind of get your feet, wet or toes wet, kind of experience this? Or is this something that you're going to worry about once you get to your job, and what your perspective has been on this so far?
Yeah, well, this is certainly a great question. I spent over a decade working to answer this question. I did an MBA in healthcare leadership during my medical schooling. And, throughout my whole process, this has been one of my, the things that I've emphasized and tried to look at. So, as most of this group probably knows, the majority of fellows are going to transition into private practice, yet we spend almost all of our training within an academic environment that's pretty sheltered from certain aspects of clinical medicine as far as the business side, right? I always try and talk with other trainees that it's not taboo to discuss the business of medicine. Sometimes those in power want you to think that way, but that's the wrong way to think. We have to remember that you cannot keep serving patients if your doors are closed. So you have to be able to understand the business to be able to actually do this work. I'd say it boils down to really 3 things for a clinician: pros, process, and profit. By pros, I'd say that's the language of clinical business. And in very simple terms, for anyone who's out there in residency right now, working towards fellowship, whatever phase, I'd say you need to be able to put your activities into a form of common procedural terminology, right? So that's CPT codes. One simple way to start that is to make a list of your top procedures, maybe top 5 to 10 procedures, and keep that next to your computer or in your procedure room. You should include some modifiers, such as the 50 modifier for bilateral procedures, because if you're not in the habit of actually putting those codes in, you're going to miss out on the work that you've actually done. You're not representing that in your billing process. That's going to lead to the process, the second phase, and that's the steps that you need to go through to get the patient to the procedure, and how to also appropriately not commit fraud while you perform the activities. So for example, if a patient shows up with buttock pain and you have a positive Gainsland, Faber, Eumann, thigh thrust, that's the med student level, right? You can do a physical exam. You can identify that this is likely an SI related issue, and maybe you want to proceed to an SI joint injection. You need to be able to look up the LCD, the local coverage determination for SI joint injections. Those are very dense web pages, but you need to be able to go through them. It's really the rule book specifically for Medicare related procedures. It's going to be very similar for other insurances too. And ultimately, they're trying to say whether a particular item or service is considered to be reasonable and necessary. And this is what you need to follow to make it that way. So in the LCD for sacroiliac joint injections, there are 6 conditions that all must be met. And only one of those is the 3 positive documented provocative maneuvers. So if that's the only thing you're doing, you might not be fulfilling the other components to that. And then looking a little bit further in the LCD, it's going to specify how you must perform and document that procedure also. And so, for example, you might have a really good skill set. You could potentially do an SI joint injection without any guidance, with ultrasound or with X-ray. But if you read the LCD, it states the SI joint injections must be performed under CT or fluoroscopy image with contrast, except ultrasound guidance may be considered reasonable and necessary, and there's certain criteria, including pregnancy, contrast allergy, etc. So it's the rule book. You have to be able to follow that. You have to save your fluoro images so that you're not retrospectively audited and fined. That's the process that you have to start getting into. It's going to lead to hopefully less denials. It's going to shape your clinical steps and how you actually get patients to the care that they need. And so you don't have delays of care. You're missing out on those documentation things. You're just going to say, oh, the insurance denied it. Really, no, it was probably on you if you didn't actually put it in the documentation. And then lastly, I'll say with that, it opens the door to advocacy opportunities. If you're familiar with this process, then you can work on changing what is required. And that can be through the form of several societies and advocacy arms that you can participate in now. So lastly, in these 3 steps I said, is the profit. So your ability to navigate your prose or the language and the process, it should lead to reimbursement. That's the payment for you and your team addressing this patient's pain. So if you navigate the system properly, you should be getting paid for it. You can start analyzing how is this going to lead to your ongoing ability to care for patients. So ultimately, your task is, and early in the fellowship process, you should say, are you able to express your patient care in a form that makes sense for work RVU and revenue models? Are you able to have a structure that as you're negotiating with jobs, that's going to make sense? So you can't worry about it later. You got to be doing it in residency and building that up through fellowship.
Awesome. So I guess we can tell that you got your MBA. Is it something that you're intending to talk about at all in your fellowship, or it's all kind of like been self-training?
It's a bit of both. I'd say there's 2 formal things throughout fellowship that we've done. We have incorporated the Society of Pain Practice Management, or SPPM. They do an annual conference and there's modules, and we actually can view those as part of one of our weeks of training that we do, like a business of medicine week. We also spend time in private practices, and locally those are with some alums. It can be a private practice or in an employed model, and we talk a lot about that. And the last thing that I'd encourage anyone to do, I spent a lot of time with our division head talking about what would it look like to reach, for example, 5,000 RVUs, 8,000 RVUs, or if you're going into a revenue model, $500,000, $1 million, $2 million. What does that look like? So you can understand those around you, what they're doing and what you need to be able to do if that's what you're going into.
Awesome. I think that's a great thing for the people listening who are applying to fellowship to consider where in their fellowship, they might get exposure to these things. So thank you so much for your answer. That was super insightful. You went above and beyond. And I think it's great because you have that MBA and that business background. So moving along to Dr. Barbaria. So a question for you would be, you'll go ahead and introduce yourself, and then I'll ask the question.
Thank you so much for having me on the panel. It's been a great conversation so far. My name is Vivek Babaria, and I am in Orange County as well, physical medicine rehab. And then I think I'm the first one on the panel that went to a non-accredited NAS fellowship, which was with Dr. Furman at OSS. And after that, I came out to California and started my own private practice. And I've been doing that since Jan 2020. So it's year 4 of being a private practice doctor, running my own business. So I don't have a formal MBA, but it's this MBA of hard knocks, and you learn a lot when you have to manage your own practice.
And that's why I think this question is perfect for someone with your level of experience, that you're well seasoned in running your own practice, and you have a lot of, there's a lot of knowledge to be learned from that. So the question is, would you have approached your fellowship differently now looking back, now that you're in a busy private practice? Is there anything you wish you paid more attention to? Things that you wish you may have honed in on as a fellow, now that you have that breadth of experience and knowledge? It's very unique.
That's a great question. And the one challenge or nugget I want to leave this group today is that I actually reverse engineered my destiny. So I knew exactly where I wanted to be. I knew the market I wanted to go into. I knew what type of practice I wanted to run. And for me to reach those goals, I thought about the right fellowship for me. And in a traditional ACGME fellowship, I saw that there were many rotations that wouldn't really give me value added to the type of care I wanted to provide. So I do a lot of orthobiologics, interventional spine and sports, see a lot of athletes from all over the world. And so for me, having the freedom to be solely MSK oriented in fellowship, and then also learn the business of medicine while I'm in it was exactly why I chose the fellowship route that I did. And I think that in itself was the greatest decision I've made in my career because I was learning the business of medicine every day. I was coding my attendings notes every single day. I was paying attention to the LCDs, the rules of what billing and coding will look like, how to bill for time versus how much extra time I spent. So whether I'm going to code it a 99213 or 214. So in hindsight, the only thing that I would have changed is that at OSS, it's York, Pennsylvania, the patient population is not Newport Beach. And so there's never a way you're going to identify, completely match your patient demographic, but like our ability to do orthobiologics and the level of athletes we were getting is just very different. And so did I get to treat the level of athletes at OSS as I did here, as I do now? No, but we definitely got to cover D1, D2, D3 schools. But the patient population was very different, the demographic.
So, and you mentioned the orthobiologics in your fellowship. So, I'm assuming, or the PRP and then doing BMAC harvesting?
Yeah, so we would do very few. I mean, I probably saw 1 or 2 PRP procedures when I was in fellowship. We did have flex time where you could do like away rotations, and I ended up rotating with Dr. Boder for my flex time. I went to Toby conference, had a scholarship to go out to Toby, so I ended up making like a 2-3 week orthobiologic rotation for myself and get exposure that I wanted.
And do you think it's important for fellows to consider exposure or at least the opportunity to do regenerative conferences? Or do you feel like you probably could still learn that as an attending later?
I think that it would be advisable to learn it when you're not an attending because it's free. For most of the conferences that you want to go to, why not do it on someone else's dime? Personally, like now, if I want to go to a conference, I have to stop clinic. I don't make revenue on that day. I have to pay for myself to get there and pay for my staff, like all my overhead I have to cover for the 3-4 days that I'm at a conference. So my thing is like, this is the 1 year where you can learn the most at someone else on someone else's dollar. So why not use this 1 year for what it's meant for and learn the most you possibly can? Whether you use it or not, at least you've got the training to do it, right? A lot of the, especially Toby, I heard Dr. Pasternak going to be there. I can't wait to see you. But the lab is open to fellows. And it was like only like $750 to like go to it. So you could get hands-on like learning how to harvest BMAC at a lab that you might not get exposure to later, you know?
I absolutely love that answer. And then I guess moving along, so the next question that we have for you is, you know, you kind of knew you were going into private practice. It sounds like you kind of had an idea. Do you have any advice for the residents and fellows, or even, you know, people who are, you know, early out and thinking of changing? How do you kind of figure out what practice setting would be a good fit? You know, like, are there certain things that may speak to you that, you know, perhaps Kaiser is a better fit for you versus an academic position versus private practice? Do you have any advice for the panel on that?
That's an amazing question, and well, I have a background in philosophy, so for me, this is a very esoteric question because I think you need to know thyself. First is what are your immediate needs, and you have to have a big vision. You have to have your vision and see how all that answer fits into that vision. So if you have needs of I need to make a certain amount of money right away, that might change the way you answer that question. If you have family needs that you need to fulfill, that might change the way you answer that question. If there's an obligation to get back to a certain region, that might change the way you answer that question. So I would say as early as you can in your training, figure out what the big plan is. And then obviously you need to have plan A, plan B, plan C, plan D all outlined. But if there's a big vision for what you're trying to accomplish, I think you could then reverse engineer and figure out which route would be best. Obviously, while you're on rotations and you feel that administration limits your ability to think freely, you feel like you will like autonomy, want to be in control of like your life and your schedule, then obviously that is something that innately will help you feel being independent would be more important for you, right? Sometimes you need financial structure. Say, I need a guaranteed salary. I want to make my money. Don't have to think about like how the billing and coding works. I just do my job and come home. That might help. If you like that kind of structure, you might decide on going on a job that allows for you to have that kind of mental freedom. And then if you're very big in academics and you want to have an academic role or career, hopefully having some FTE and some money guaranteed, protected time to do research and are forced to do research in that setting, and that's your passion, you can definitely do that. What I can say is that being a business owner, I have the freedom to do it all. And being on PSPS or part of SIS or any other society that I'm in, I'm still publishing a lot. And I like to call it privademics. Like we get real world data. I might not be, I'm not asking for grants, but I have clinical data that I'm allowed to and able to publish because we're trying out different things that I have the freedom to do, right? Like if there's a certain procedure I want to try or attempt and I have the data to support it, I don't have to ask 10 different people and the bureaucracy of whether or not it should happen or not.
And how realistic do you think it is for somebody to open a private practice like you've done? Do you need to build the foundation? Do you usually recommend like, working in a group or, that transition? Because there's a lot of, learning that's done in the first couple of years out of fellowship.
It's definitely very challenging, but I think that just requires a lot of homework. Obviously, again, I don't have a business background, but being Indian, like every Indian's a business person. So like thinking about how to right. So the two things in business is how do you keep your overhead down and maximize profit? But you have to do market research. Like you can't just say, okay, I'm going to go in the middle of nowhere and like start a practice. Like for me, it was a lot of research that I did before I came out to Newport. How many pain docs am I competing with? Like how do I develop the actual brand before I even get there, were things that I started doing as a PGY3, So like 3 years before, I was like laying down the groundwork of having a website, starting to create some buzz, networking, coming out to California, conferences, rubbing elbows with people who are in private practice and understanding the lay of the land. I would say the biggest thing that was a shock for me is how Southern California insurance market works. Regardless of how much training I had at OSS when it came to billing coding, understanding HMOs, IPAs, PPOs, like all these small managed care plans was a whole new world for me. And I still don't get it, to be frank. But there is so much about how money moves in our world that if we don't awaken in this sense of learning how money moves, we will really be just an employee in this big system. So I really want to empower you guys to at least understand how money works in our field.
Yeah. And so to kind of wrap up this section, one thing I will say is, it's incredible that, you started a private practice in Newport Beach. It's a very competitive area. So that's a major kudos to all the, younger fellows, residents, young attendings. It's really important to know your payer mix. And if you are going to do private practice, to do exactly what he was talking about, it is incredibly complicated. Maybe if you go, somewhere that isn't as saturated as an Orange County, a San Diego or LA, you can walk in and people will literally just send you bucket loads of patients and reimburse you well. But in the more saturated areas, they will really squeeze you as a physician. So I think he made a huge point. And then, going back to Dr. Gill, and actually both panelists kind of said this, is that as physicians, you need to know the finances, because if you don't, we're basically putting the power in the hands of the insurance companies, and they will dictate your care. They will shrink your time and you will give bad care. So putting your head in the sand is not gonna be the, solution. It's not about being business savvy. It's about advocating for your patients, and you have to keep the doors open, as Dr. Gill alluded to. So thank you all. Thank to both of you. You guys were phenomenal panels. I feel like I'm learning too. So this is great. So I'm going to go ahead and wrap it up and pass it off to Dr. Katzen to finish us off.
Of course, that was a great section. If you're watching this and you're at the resident or even fellow level, Dr. Barbaria's mentor, Dr. Furman, basically wrote the book on interventional pain. So make sure you pick that up if you don't have a copy of that, because that should be in every interventionalist library. Okay, we're going to go ahead and move on to the next final section here. This is entitled Early Career Realities and Challenges. We have three practicing attending physicians, Dr. Meesum, Dr. Bondal, and Dr. Gandhi here, who are going to answer some questions for us. We're going to start with Dr. Meesum, and I'm going to go ahead and have him introduce himself first, and then I'll ask you a question.
Okay, thanks, Seth. My name is Dr. Meesum. I'm based out of northern Utah, but cover areas in Idaho and Wyoming as well, and mostly work out of rural areas.
So awesome. So we're really happy to have you here. The question for you is, how important do you think it is to involve a lawyer in your contract process when looking at jobs? And what level of detail do you think things need to be spelled out in a contract when you're negotiating the perks, terms, partnership, profit sharing, things like that, etc.?
So for both parts of that, having an attorney to go over the contract with you, I think, is absolutely essential. Unless you have your own law degree and are specialized in the, in the labor law of the state that you live in, I think it would be very foolhardy to do otherwise. Labor law varies significantly from state to state, is very complex, and is not so simple as just, like, oh, like this is a non-compete here, or you can compensation in this way, or what the restrictions could be. There's lots of subtleties within that of what's legal in your state, the difference between non-compete versus non-solicitation, how that applies in your state if you work across state lines, as in my case. Is there jurisdiction in one spot over another? There are so many things that there's so many subtleties within that. You absolutely have to have an attorney look at that. And I think when it comes to the level of detail, I would say go over it with a fine-tooth comb. Everything is, everything that is vague will remain vague and can be a question. It opens up to potential for expensive litigation down the road if you're not careful in looking at that. You want to go over what does salary look like? What do bonuses look like? What does that structure and incentive look like? I think a big thing, particularly if you're going into private practice, is making sure that you have access to certain information and guarantees of access to information, such as financials, what you're producing, what your overhead is, what kind of RV, if you're going off of RVUs, what you're generating. This information is not always, readily available from owners to non-partners. What does a partnership agreement look like? And so I think that all of that and having it spelled out is essential, because if it's not spelled out, it's not a thing.
That was great. I'm going to go ahead and move on to Dr. Bondal here. So Dr. Bondal, go ahead and introduce yourself before I ask you a question.
Yeah, absolutely. Hi, everyone. I'm Harjot Bandal. I'm anesthesia background, currently practicing up in Northern California, about an hour from the Bay Area. And I've been in practice for about 3.5 years.
So the question we have for you is, any specific questions that you would have asked your employer that you're with currently or prior before you started? Go ahead and go with that.
Yeah, I mean, I think, this is a pretty loaded question. Can probably spend a very, very long time on this. Talking to a lot of friends across the country, you always kind of, look back and say, oh, I wish I would have known this or known that. So I try to kind of pick out some of the more important things. As everyone has echoed, the main thing is we're not trying to be greedy, but you do have to get reimbursed to live, eat, feed your family. So make sure you're really clear on your reimbursement and how that's going to happen. Generally, there's 3 models. Usually when you're coming out of training, having a guaranteed salary is usually the best, because it's going to take you a little bit of time to ramp up to it. So be really careful if someone is saying, oh, well, everyone here makes $500,000. We're all going to be production based. Here you go. This is your production based model, just like us. Chances of you actually hitting those numbers are quite low when you start out. So make sure you're comfortable knowing that. And then if there is some type of a production model, make sure you know what the goals are, how much each RVU is worth, how much the collections are going to be going into your pocket. So just like Dr. Mason was mentioning, make sure all of that is in writing. And a lot of people these days are obviously going after hospital employment just because of it takes away a lot of the headaches. But I would definitely, encourage people to look into private practice because there's a lot of opportunity for growth there. But at the same time, looking at private practice, there's a lot of kind of promises of partnership. So you really want to take that into consideration as well. If there's a lot of partners that are already, they may say that we're going to bring on a partner, but if you notice that the previous employees have been there for 2-3 years, and then all of a sudden they leave, and then another person comes in, stays 2-3 years, and they leave, the chances of you becoming partner are probably slim. This might be one of those kind of revolving door kind of places where they bring in new grads, have you work 2-3 years, and then you kind of figure out, oh crap, I'm kind of not in a good deal, and then you end up leaving, going somewhere else. Other thing would also be make sure you really know what you're getting into in terms of your schedule. So really have them outline that for you, exactly how many patients you're expected to see. If there's multiple locations, where are you going to be going? How often are you going to be going there? Because there's usually no increased reimbursement for you travel, an hour away somewhere to see patients if you're going to be making the exact same amount of money if you were kind of staying at your home base. And then the other thing, as far as, Dr. Mason was mentioning, looking at the financials of the practice, I think that was something that I kind of had to struggle with because most likely private practices aren't going to open up their books to you. You're just a random person interviewing there. So they want to make sure that you're kind of vetted. So I think it's okay to not get a lot of those financial details right at the beginning. No one's going to want to let you look under the covers, but just expect that there's some type of a consideration that when you have spent, 1, 2, or 3 years, whatever the partnership track is, that eventually you'll be kind of privy to all that knowledge, and then you can make a wise decision regarding partnership.
Fantastic. I've got one more follow-up question for you. You've been in private practice for a little bit now. What were the most unexpected challenges going from training into the real world that you've noticed in your career?
Yeah, so there's a lot of big changes that come, a lot of things you won't expect. The main thing, as people have kind of echoed, would be fighting with insurance companies. You spend so much time on prior authorizations, so you'll eventually kind of learn to look at all the LCDs, the local coverage determinations. So, a few years ago, months ago, I basically sat down, looked at all the LCDs, and just templated all my notes based on the LCD. So that saves you a lot of time. So a lot of those things you'll kind of find out as you're going through your daily routine that'll save you time. Other thing also is there's really not a great kind of interdisciplinary teams available out in the real world in private practice. It was great in fellowship. You had a pain psychologist, you had a pain specific physical therapist, you had a pain psychiatrist, all these people just kind of at your fingertips. You can send out referrals, but in private practice, it's pretty tough. There's usually no pain psychologists. You're kind of searching for even a good physical therapist who understands CRPS for a lot of pelvic pains. So that can be quite challenging. So that's where kind of networking, finding some of these people becomes really important. And then finally, just finding a balance in when you're attending is important because sometimes you just have to learn to say no because you're going to be busy the first few years. You're going to be trying to grow your practice. If you're in private practice, that means anytime that you're not seeing patients, you or your employer is going to want you to go out there, network, go to dinners, go to lunches, meet referring, physical therapists, surgeons, family physician doctors in the area. So that can take up a lot of time. And then obviously you're trying to also stay engaged with research. Maybe you're part of a society. You want to get into industry, talk to some of the reps, go to some of the conferences, maybe speak for an industry. So a lot of that can take up a lot of time. So you also want to make sure that you're kind of taking a look at your work-life balance. As Vivek was saying, it's really all about what you want. So make sure you kind of structure your life and your practice based off of that, because there's tons of jobs available out there, and you can definitely find one that really fits that.
Amazing answer. I appreciate that. Thank you. So I'm going to move on to Dr. Gandhi finally, who is also another attending physician. We're going to get some good perspective here. He's been in practice for a while. Dr. Gandhi, could you go ahead and introduce yourself?
Yeah, so I'm Pratik Gandhi. I'm also in Northern California in Stockton. I'm part of a 10 to 14 orthopedic surgeon group in Stockton, California. Been in practice for 7 years. I did my residency in PM&R and then a spine fellowship in Seattle, coast to coast. So, coming down from different locations was definitely an eye opener.
Well, we're happy to have you here. The question for you is, in your first or second job, what are some potential red flags that would warn young attendings to look out for?
Yeah, so that was, one of my first jobs. Lucky for me, I've sort of been in the same role since I came out of fellowship. Not saying that I didn't interview in multiple spots. I think the real kicker here is that when you're coming out of fellowship, whether it's academics that you want to do, private practice, the privademia that was mentioned earlier, you really have to look out for people sort of taking advantage of your services. That's one of the big things I learned right from the beginning. Academics notoriously, if you're looking income wise, and we know that it pays less, but there's a little bit more security, if you want to call it that. When in private practice, the ceiling or the ceiling is a little bit higher, but you have the capability of molding however the way you want to. That's how you have to look at your lifestyle. If you want freedom, a lot of places where you're employed or academics, you won't have that. But I think the biggest thing is, there's groups that have partners that have been there for 30 years, 35 years. So you have to really get a good gauge of what the overhead structure is if you're doing private practice. They may be working 2/3 of the time, but then kind of mooching off or, milking off some of the work that you're doing. These are changes that happen. If you have a board, our practice luckily has, 10 to 15 members that are all equal share. So we learned how to navigate the old overhead system that was in place, to get a little bit more sort of equal. Partnership is big. So when I interviewed, it was more of what area needs it. I grew up in the New York City area, so that area is, very, very saturated. So there was opportunity, but it was at a cost. When I came down to Stockton, there's one other pain doc, 2 spine surgeons, and 10 orthopedic surgeons in one group. So the first question I asked the pain doc is, how far out are you scheduling your new patient visits? And that was an automatic 3 to 4 month, answer right off the bat. Followed him in the OR and he's plugging away, 7 to 5, just plugging and burning injections. So that was the first thing, is how busy can you really be? And then looking at what's around in the community. They have, our practice is the only one really in town. Obviously, aside from Sutter, Kaiser, the big hospital organizations. So once we learned that, hey, everyone gets referred, whether it's for back pain, neck pain, knee pain, the one-stop shop was this practice. And then it's a little bit of faith. So my contract was negotiated in a way where I had 1 year guaranteed. And then, a big fall off the cliff, building up practice. And California is a different animal. You have to take time to be on insurances. You have to take time to get a fluoro license. So when you sign on, you're talking 6 months, 7 months down the road when you actually, start seeing volume. And then your guaranteed salary may kind of take a dip, and then you have to work your way back up. So that's all sort of reality is, yeah, it may look good at first. There may be some rough times, and then it may come back. I think a big point is also looking at the history of the practice. Practices that have a 90% retention rate, people who start and finish their career there. There's a lot of volume, as you said, about that. What are the relationships with the hospitals in the area? Being pain doctors, is there an ASC? Is there an ASC buy-in? Are you able to be a partner at the ASC? All of these, factors kind of blended in. Or are you simply working for a bigger conglomerate like a Kaiser, like a Sutter, where, you can have a good work-life balance, but you also have a ceiling. And if you understand that, then that can work for a lot of people as well. But that was the biggest kind of going into, looking for those red flags. Did people leave within 2 to 3 years, as other members kind of mentioned?
Yeah, I think those are great points. I'm actually leaving my practice that I'm in currently soon. It's my first practice out of fellowship, so I've been going through this process myself. And something I would add to what you say. I think what you said was amazing. Like all of those things to look out for. But if you do decide to leave a practice, like leaving on the best of terms is very important. Would you agree with that? Like making sure you have, I'm in an ortho group right now. I have a very good relationship with the spine surgeon that I'm in. I'm going to a pain group. And you know, I want him to continue to refer to me. What are your thoughts on things like that, like with the relationship? Because things can get sour real quick in private practice medicine if you're staying in the same area and you're going somewhere else. What do you think about that?
Yeah, those are, it's always good to leave on good terms. I haven't run into many that have not. It's very hard, and I'll be upfront. And it's when you're part of an orthopedic practice, your overhead is quite high. It's just the nature of the beast. Across the country, especially in California, you may be looking at 50-60% overhead. When you're in a pain practice, you're looking in the 30%. So the relationship is more like, hey, I feel like I'm doing a lot of work, but I'm not seeing the fruits of it. It's just a frank discussion to have with the partner is, what's the reason for leaving? Are you unhappy? What's the reason? There's always a fear that they can hire someone else, right? That has run through our practice many times where, hey, if either one of the pain partners leaves, what's to say that the spine guys aren't going to hire another pain doctor into the group? It's acceptance and understand that, there's enough patient loads around where you could both kind of live, coexist basically in the same town or within adjacent towns. And that's the relationship that you have to kind of set forward. I had a surgeon who left the practice, and we're still getting referrals back to us just because of the relationship. So it's just an important discussion to have.
Absolutely, couldn't agree more. So guys, thanks so much for your time. You guys did an awesome job, had really great insight. We really appreciate it. I'm going to go ahead and hand back over to Dr. Mohamani or Dr. Lee, whoever's taking over, and thanks so much.
So I'll just let Dr. Lee, he has some like last minute close up things, but I just want to echo the points that were just made. I think you have to be nice to everybody. And you should always be nice to everyone, not just because of karma, but I mean, I have friends from undergrad sending me referrals now that I'm in private practice. So you never know. So try not to burn any bridges as much as you can, which goes without saying, but it's a small world.
Yeah, I agree with that. Thank you guys. That was amazing work. Appreciate it that all the panelists for all their time. It was kind of a design. This whole thing, the inception of this was really designed to kind of take all of you guys who have taken the time out of your evenings to tune in here to really take you through that entire journey that we all go through individually, from kind of inception of trying to decide what do I really want to do with this medical degree, to eventually getting to a point where you're established in the community and you've made a name for yourself. I've been doing this for now over a decade, so I can kind of appreciate that. And this webinar was amazing to me because I kind of like look back. I will say one of the most inspirational things for me is simply that a lot of these people that you're listening to on the webinar are way ahead of the bell curve, as to where I was in each of these aspects of their career. I mean, I always joke around, like early on in my career, I was just trying to figure out like what residency or what kind of subspecialty I wanted to do, and it wasn't until later on where I actually even learned what PM&R was, and then after that, that I wanted to do something interventional, work with my hands a little bit more. So this has been amazing advice, and a lot of pearls have been dropped here tonight. So awesome. Thank you, panelists. And Dr. Mohamani, Dr. Katzen, amazing in terms of your guys' work in moderating this webinar. It's not an easy thing to do. I've done it before, and so I really, really appreciate your guys' time. I know we're running at the hour now here, so just real quickly, guys, we are, of course, organization PSPS. So our actual conference is coming up. It's going to be in early October. It's going to be in Orange County. So yes, thank you for that slide. So this is a QR code for those who are tuning in here. It's going to be at the Pendry Newport Beach. This is kind of right in our backyard. Seth, Roya, and Mayan as well as some of the people who have been involved with this webinar. The Pendry's amazing hotel. It's just recently been built. It's going to be right in Newport Beach. So we hope that many of you guys who are on this call can join us. The LIP members will all be there. We're going to have like a little separate section for LIP members as well. So if you heard anything great on this call, you'll be able to interact with them and kind of pick their brain, so to speak. Can I go back to the previous slide? Thank you. So as part of this, thank you. As part of this, we're calling for abstracts. I know there are a lot of different opportunities to submit your abstracts to, but as the original panel had discussed, make sure you guys find, simple things. You guys, it doesn't have to be level 1, level 2 type of studies. Certainly if you're earlier on in your career, the expectation for that is just, kind of way too high, but you start off slow and you kind of grow into doing more and more research. So an easy way to do that, as some of our panelists had suggested, as Robin had suggested, is you find this case reports, interesting case studies, and you kind of use that as kind of your foot in the door to doing bigger and better things. And I know that that's how my career started as well. You find these interesting case studies, you submit them, you go to these different meetings, and then you kind of blossom from that point on and figure out oh, what's my interest here? Definitely one of the things that helps kind of get you guys excited about doing this, that we do have rewards for some of the top abstracts as well. So that would help subsidize people's travel expenses. The other thing that we do at PSPS is we do try to encourage some time of research. It's both in pain and spine. So every single year we try to look at these research grant proposals that have been part of that review process. And then we choose a particular study that's available out there. So many of you guys on the call may have like a study in mind, but you're like, I don't have the resources to do it. I don't have the funding to do it. Well, this is the opportunity to kind of tap into PSPS to be able to do so. And I'm sure that even some of the participants on this call certainly may be interested in this. So please keep that in mind. I'm going to, without further ado, I'm going to kind of wrap things up. But Alan, Dr. Lin, do you have any final comments or thoughts here before we sign off?
And of course, tonight you just I didn't realize the time goes so fast. Truly very good topics. But I would suggest you guys continue the discussion. We don't have time for any answer, or different people have different opinion. Please use social media, and also and Dr. Lee, me, and pretty much everybody welcome you guys. Please join the annual meeting. There will be tons of fun, and it's not going to be boring. And then that would be the first lead actually meeting since it was established about 3 years ago, right? And then that we will have some fun moment together. And but appreciate it. I think we continue the connection, and then from all the social media, especially the WhatsApp group, and then any question or demand, requests, and anything, feel free to throw it there. I try my best, kind of handle it, process it, and make sure the time is not wasted.
Yeah, absolutely. And Dr. Lin, you've been invaluable in that process. Thank you guys again on behalf of Dr. Mohammadi, Dr. Lin, Dr. Katzen, and the rest of the panelists. Thank you all for joining us. Have a good night.